We'll just hurry and run through some of the upcoming events. Just remind you that like Significant Other Spouses Night is Wednesday the 19th at the 6 o'clock at the Student Union. We are having significant others of people who are, of individuals who are, have gone through the medical school residency. So you can ask their, get their opinion of how it was having a significant other go through all the stuff we want to go through. Then our service project for AMSA is March 22nd. It's a Saturday. We're going to help out a Habitat for Humanity. It's tentatively at 9 o'clock, but we will get some more information out. Then there's also a science fair. Science fair opportunity to judge for junior and seniors in high school. And they need volunteers for that. That's another way to get good service hours, and they will provide lunch. The website. Is anybody? Or should I just write the? Just write it. I'll just turn it right on the board. So you just go here to register. Fair.org. Okay, and then lastly, April 4th is going to be the deadline for the AMSA officers' applications, and we will be, if you're interested, we'll email or get hold of Adam. Sorry, Adam. Get hold of Adam. And then we'd like to thank Dr. Trask for coming and speaking with us. He is a hospitalist and an administrator at McKay Dee, right? Correct. Okay, we'll turn the time over to him.
Okay, thank you. So, appreciate the opportunity to come and talk to you all about my career in medicine, and I want to make this informal for two reasons. One is just I want to generate discussion so you can ask questions as I go along. And secondly, I worked last night and I didn't get a lick of sleep. I had meetings this morning and I got to bed around 9:30. So if I'm a little punchy, I apologize. I have my cup of caffeine here to keep me going, so bear with me and let me know if I get too chatty or too hyper. So first of all, I'm going to give you my email address. If you have any questions, please feel free to email me. I'll try to write neatly, because I do have doctor's handwriting. So at yahoo.com. So feel free to give me a call or email me if you have any questions. Who knows what a hospitalist is? Oh, I know you know. Okay, so a couple people. Let me tell, so a hospitalist is, I'm an internal medicine doctor by training, and I focus my practice solely on inpatient medicine. So I only work in the hospital. I don't have an outpatient practice or have my own panel of patients. So if you come in the hospital and you have a medical problem, you're going to get me or one of my partners. How I got to, I'll just give you a little bit of my bio, just how I got to where I'm at. I grew up in Philadelphia, went to University of Pennsylvania for my undergraduate degree in biochemistry. I originally actually thought I was going to go to medicine when I was in high school in the first 2 years of college. Then I started doing research, and I really got into research, and I wanted to get a PhD. And my mentor at the time said, well, funding is pretty tight with the NIH, and you might be able to get more directed research and better chance of funding if you get a combined degree, MD, PhD. So I said, sure, why not? That sounds easy, right? So I took a year off after college because I had to study for the MCAT and just kind of get ready for that. Went to Washington University in St. Louis for my MD, PhD training. It was a combined program. It was 8 years total length. It was 4.5 years research time, 3.5 years clinical time. So I got 1.5 year less of clinical rotations for your fourth year. I met Barb in the lab. I'm not sure if you all know Barb. I know she's moved on. So met my wonderful wife there, and then came out to the University of Utah to do my residency in internal medicine, which is a 3-year program. And I graduated or finished my program in 2003, and since then I've been working at McKay Dee Hospital as a full-time hospitalist. And I'll tell you about some of my administrative roles that I've taken on as well during that time, just to give you an idea of the breadth of really any career in medicine. You can do administration work, and kind of the joys that I found in it as well. So one of the questions, I brought my cheat sheet here. The email was to talk about the difference between how hospitals work and how they compare to internal medicine physicians. So again, I am an internal medicine physician. Does everybody know what internal medicine means? So basically, the way it's characterized is doctors for adults. So I don't do pediatrics, I don't do surgery, I don't do deliveries, I don't deliver anybody, and I don't do psychiatry. So I just focus really on major problems like diabetes, hypertension, heart disease. If people come to the hospital for pneumonia or strokes or heart attacks, I'll take care of them. And so I'm just going to kind of compare and contrast, because I did have the opportunity, and I thought about it going into primary care and have my own practice. And there's obviously pros and cons to anything that you're going to do. And I just, as maybe a piece of advice, is no matter what you do in medicine, make sure you really love it, because it's a hard profession. It's hard on your family. You lose a lot of sleep, like I'm showing you right here. So you really have to love it. People sometimes go in it for the money, and the money is great sometimes, but let me tell you, if you don't enjoy your job, it doesn't matter how much money you make, it's never going to satisfy you, and you're just going to want more money. It's really, I've seen it happen to a lot of physicians, and it's kind of ugly to see. They just get bitter and depressed and just not very happy, and it doesn't work out well for the patients if you don't have an engaged physician taking care of you. So let's talk about hospitalist versus primary care. So just to give you a kind of a highlight of, I'm just going to write PCP for primary care physician. Also PCPs can be family practice docs, and they get more broad training, OB, pediatrics. I'm not sure how they keep all that information in their brain, so I'm not that smart. So my typical day, well, so the way our service works, we have 13 partners, and we all kind of work together as a team. There's kind of 3 different roles. One could be an admitting physician, so either at night or in the evening, where mostly people come from the ER, they come in, they're sick, they say, oh yeah, you need to come in the hospital, and then we'll admit them, take care of their medical problems while they're in the hospital, get all the information to their primary care doc when they leave. The other role is if you work during the daytime, you'll pick up those patients who are admitted, you'll follow the patients during their hospitalization, take care of them throughout their course, whether it be a week, 2 weeks, 2 days, 10 hours. So I've solely focused on working nights over the past 3 or 4 years for a number of reasons. I'm kind of a night owl. It's a little bit more quieter in the hospital at night, so I have a chance to think. And working at day, you're just go, go, go. I never eat lunch, and it was too much stress for me. So let's talk about, so any questions so far about hospitals? You have kind of a general idea of what I do? Questions? Yeah, absolutely.
So you said you don't do any pediatrics. Who's the hospitalist that takes care of the pediatric patients during the nighttime, I guess would be my question.
They actually don't have a hospitalist program for pediatrics. They're trying to get one. It's a lot of issues as far as reimbursement and things like that. So actually, in the old days, the internists would admit their own patients to the hospital. So they'd be in their clinic all day. They may have to go to the hospital to admit a patient. They have to come in at night if there's an admission. And so that's what the pediatricians are doing right now. Hospitalist medicine has been around, probably around 10 years now. And it makes a lot of sense because we really just focus on inpatient medicine. And folks today are living a lot longer with our advances in healthcare, technology, medications, and so people have a lot of chronic medical problems. And to be able to do both, keep up to date on the outpatient and then the inpatient side is really too much. We're there 24/7, so if there's a problem, we're there right away. If families have questions, we don't have to say, well, I'll be by after clinic at 6 at night. So the docs have a better lifestyle. They get to focus on what they're doing. They can be more available to their patients. I just focus on the inpatient side. We do shift work pretty much like an ER physician, so I work from 9 at night till 5 in the morning. When I'm done, my partners take over whatever issues arise. So it's a little bit better of a lifestyle that way, although that wasn't the main factor of why I went into it.
Dr. Trask, the one thing I didn't understand or didn't know was that when you're in the hospital, you're not going to see your primary care physician. And I didn't realize that.
Yeah, that took a lot of time to get people just used to the idea. And I think at first patients and families are like, what do you mean I'm not going to see my regular doctor I've known for 50 years? But I think that the flip side is you have someone available all the time. And you know, we're experts in inpatient medicine. That's what we do. That's only what we do. Some of the other responsibilities in the hospital, so if there's a code blue, so if there's a medical code, I run the code with the residents. I let them run it. I just kind of supervise, get them experience. I'll do consultations for other services. So if someone's coming in with a hip fracture and they need to be medically cleared, I'll do that. Just make sure that they're optimized for surgery as best they can. We get a lot of consults from psychiatry if they have any medical issues they're not comfortable with. So we're really the resource for the hospital for internal medicine. So some of the differences between the two, obviously since I'm on the inpatient side, we really deal with mostly acute problems. So if you come in and you've had chronic pain for 10 years, I'm not going to fix that. I mean, I'd like to if I could, but that's not really what I'm focusing in on. It's really what brought you to the hospital, your pneumonia, your wound infection, your uncontrolled diabetes, things like that. While for your primary care doc, that's more of a chronic management for these things. And certainly diabetes is a chronic disease, so they do need that chronic management as well. So obviously one of the things here is I don't have continuity of care. I don't have my own patient panel, although some people come in the hospital a lot, so I feel like I know them really well. But I don't have that longitudinal relationship. That's one of the downsides. So I didn't tell you, so I did my MD PhD, and I decided not to do the PhD part because I really enjoyed working with patients. I enjoyed the clinical challenge to figure out what's going on. And so that's kind of why I focus just on medicine. That's one of the downsides of not going to primary care for me, with not having that longitudinal relationship. I kind of like the acute stuff more. It's kind of more exciting. You fix them, you see what's happened, they get better, they go home, you feel like you've done a good job, versus some of these more chronic issues where sometimes you never fix them. It's really just kind of managing them, make sure, helping them kind of live with their disease to the best that they can. One of the big things as a primary care doc, you're pretty much, I mean, you may be in a group, but you have your own panel of patients. So really, anything you do right or anything you do wrong is really on you. In my practice, though, this is we affect each other's care. So I may take care of someone. I pass them off in the morning. Someone else takes care of that patient. If I screwed up, I did something wrong. Well, now all our names are on that chart as far as like a malpractice lawsuit. So one of the challenges is having a good group of docs that you know gives quality care. Because I've been named in one lawsuit that I know of so far. I got dismissed. Not I didn't do anything wrong. But these lawsuits happen, and everyone kind of the net gets cast wide to bring folks in, and so that's one of the issues with being a hospitalist as far as that kind of group liability. Let's see. Some of the things with hospitalists too, so we're really integral to the hospital operations. We sit on a lot of committees, we help design care processes, how are we going to optimize diabetes care when people come in the hospital. To me, that's really exciting. You get to really change how care is provided at the hospital. You can do that as a primary care physician, but it's more based on your patient panel. And so we do a lot of, like I said, a lot of committee work. We do develop a lot of care models and help change how the practice is done. And we try to standardize the care within our group too. So I'm not doing A while my partner's doing B, and the patient's wondering, well, you know, do you know what you're doing? Because you're doing one thing, he's doing the other, don't you talk to each other kind of thing. So it takes a little bit more coordination. And this is more of a team approach that way as well, which I kind of like. As you go through medicine, really medicine is a team approach no matter what you do. It really is a team approach of nurses, physicians, social workers, case managers, your office staff, no matter the OR staff if you become a surgeon. And so medicine really is a team sport. Just a word of advice, don't diss the nurses when you're in residency. It will hurt you in a lot of ways. This obviously for a PCP is more business oriented. I mean, you have to run a business and you have to make ends meet. I mean, I do have to worry about that to a certain degree, but I don't do my own billing. I mean, I put my charges in someone, I just hit the send button and it goes somewhere and somehow the money comes in. I don't have to worry about that for me, which is nice because it's hard enough to practice medicine rather than running a business as well. One thing I like working with Intermountain is that I'm payer blind, meaning I don't look at what insurance people have because I don't care. I'm going to treat them the way they need to be treated regardless of whether or not they can get paid. Now, certainly I'm not trying to say I'm going to rack up your bill because I can do that. You know, I'm cost conscious, but I don't have to worry about it. And I think when you're in a business practice or a solo practice, you kind of do have to worry about that to a certain degree because you have to pay your staff, and if you don't have any money, you can't keep your doors open. So that creates somewhat inherent conflicts of interests. You know, if you have an MRI machine, guess who, you know, if you have one practice who has an MRI machine and one person that doesn't, who thinks does more MRIs? What's the person who has it? And it's easy to self-justify what you're doing. because you have that machine. And I'm not saying that people do it intentionally or they're trying to do things wrong. I just think you get in the mindset as well, gee, well, you know, well, we can see that bite number, right? Well, we have one, let's just check that out. Not realizing that may not be, you may find things that you're not want to look for, you find that are really meaningless, but it creates a lot of tests and a lot of anxiety for the patient that maybe not warranted in the first place. Questions so far on this? Yeah.
I guess just working as a group, I mean, you say you like it, but I can imagine it, I mean, maybe it takes getting used to, but I imagine a headache if you're going from patients that you probably have only seen once or twice, and then they've had all these things happen to them from different physicians. I mean, is that hard to keep track of? Or you say you enjoy that, it makes it more fun and challenge, or what would you say about
Well, there's always a flip side to everything.
Yeah.
I mean, it is I do enjoy it, but it is challenging because we do, to a certain degree, have differences of opinion on how you treat things, and there are no standards of care of how you should treat everything. A lot of it comes down to your opinion and your experience, and some of that is having hard conversations of like, well, what the heck did you do that for? And I try to promote an open atmosphere for people to come to me, and you know, because I don't take it as a criticism. I think it's just more learning, and it really takes a strong group to kind of develop this kind of group think and being able to talk about these things open and not being accusatory, not feel like you're being attacked as well. And we've had some partners that have been kind of done things that were a little like, what the heck were you thinking? And those are hard conversations to have, but you know, to some degree you need to do it because you're liable as well. And you also have to think what's best for the patient as well. And sometimes there is no resolution. You have your style, I have my style, and you just learn to live with it. So some of the things that are common for all of this is standard, I'll just put this in the middle, is keeping up on the standard of care. I went into internal medicine because I wanted to be the doctor's doctor. Boy, did I bite off more than I could chew. This is a huge field, and it's hard to keep up. I just had to recertify for my boards. Every 10 years I have to recertify. Sit for an exam, I have to do modules, I have to do projects and all this. And you know, at first it was a real kind of pain in the butt, to be honest. But I actually learned a lot, and things have changed a lot in 10 years since I took it originally in 2003. One of the folks who works down in Salt Lake actually didn't pass the exam. Had a 30% fail rate. Which is kind of crazy. I don't think it was the best exam, but still, it's kind of a big stress to go through it and not get to the next stage. I'm sure he's going to pass it. I would have him take care of my mom and take care of me. He just was a bad day for him, I guess, on the exam. So, but it is pretty rigorous, and there's a lot. I was drawn to the breadth of knowledge. You know, I get to learn a lot about a lot of things. But I'll tell you, when I was working a night last week, I had 9 admissions in 8 hours. And these are sick folks, because in order to get in the hospital, you have to be pretty sick to begin with. And when I get a call from the ER doc and they say, I have an interesting case for you, I'm like, I don't want interesting. I want to know what's going on, I know what I need to do, and can move on to the next person. In the meanwhile, I'm taking care of 60 other patients that my partners had, that I'm doing cross-cover calls. If someone's having pain or chest pain or their blood pressure is low, I got to deal with that, and you know, codes go off, and it can get stressful. So sometimes interesting is not very good. But it's hard to keep up, it really is. I mean, you want to enjoy your life, and I am a full proponent of having a balanced life. I think the doctors of yesteryear had it wrong. You know, working to the bone, going through several divorces, not knowing who your kids are, not raising them, I think is wrong on many levels. Personally, as well as for your patients as well. So, so it's hard, but you have to do it. Government requirements. This is huge. The amount of regulations that we're under as far as, right now they have these things called core measures. So people who come into the hospital, for instance, have to get a pneumonia vaccination. That's one of the things. If we don't do it, the hospital gets dinged millions of dollars for this. So it's a big thing that we're being forced upon external forces to do these things. And certainly they're the right things to do for the patient. Some of the measures that you can imagine are, well, it doesn't really fit in this situation, but it's kind of hard to make it, you know, they make it a hard and fast rule with a few exceptions, but still it's hard to keep up to date in all these government regulations. How you bill is important. Medicare comes out, you know, what they call fraud and abuse really is what I consider is sometimes a matter of opinion. You know, all this fraud and abuse really isn't doctors trying to take advantage of all the taxpayers. I think it's just difference of opinion as far as how you say, I say A, they say B. Well, they're the ones paying the money, so they get more weight and they make the final decision. So, so there's a lot to deal with that. End-of-life care, I deal with a lot of end-of-life care in the hospital. A lot of times folks come in hospital and they're sick. In fact, the phrase I usually use is that at some point everyone passes a threshold from prolonging life to prolonging death. And that's a hard thing to have a conversation with the family that you just met 5 minutes ago, but you realize what's in the best interest of that patient is like we're not doing anything to save their life. We're just prolonging them dying. And really what are their goals, and to have that conversation. Certainly you have to deal with it as a primary care physician and kind of work with them as their disease progresses and kind of work out these goals of care, which really helps us that patients are aware of kind of how sick they are. And I think it's hard to have those conversations with someone and say, you know what, I'm not sure this is really working for you. You know, what are your goals? I'm not sure we can fix this. And it affects a lot of people. It's the first time they're hearing it, and you're kind of put in the bad position of being the bad person. But in the end, I think it's the right thing to do for them, because you don't want to do futile things that really have no benefit for the patient. So, so those are kind of like the major differences between the two. Some of the things that I'll tell you my biases is I don't do well with like chronic pain, chronic anxiety, depression. Like for me, that's just hard because I just don't have those skills to I don't have that touchy-feely side. So that's why I would never go into primary care practice. I think that there's a lot of that in there, and you know, it's for some people, and I'm not saying that it's wrong. You know, I'm glad there's a lot of people going into medicine, so we all fill the roles, but that's something that I would not want to do. Some of the other, I mentioned before, some of the other things I was thinking about for residency were pediatrics. Which is similar to internal medicine, just, you know, just younger people. But I decided not to go in it, and really the main reason is because of parents. You know, if there's a patient that comes in the hospital and they have diabetes, they don't take care of themselves, I have no problem saying, look, I can only do so much, you have to take responsibility for your own care. It's kind of hard though for a child when it's the parent that gets involved. That creates a lot of issues. I just didn't want to have to deal with that. Again, some people can do it and they do it really well, just not for me. I thought about dermatology, kind of would work well with the research that I was doing for my PhD. Until I did a fourth-year rotation, went to lunch and had a big lunch, and I came back and someone had this big old boil on their back, and I had to pop it, and it was the nastiest thing. My stomach turned, I got nauseated, I said, this is not for me. Some people like it though, but so I kind of ruled that out real. Surgery. Yeah, I wasn't real interested in surgery. It's a hard training program. Some people love it. They like that power, you know, and I think it is an adrenaline rush for them, but I don't like getting up at 4 in the morning and doing surgery all day. This, you know, for some people it's great, but for me it just wasn't worth it. It's a hard training program, and even the general surgeons in our community, they work hard. They work like dogs, and I know it's hard on them, it's hard on their family. You know, they love what they do, which is great, but I think you just as you go through medical school, as you decide what you're going to do for residency, you'll find that it's easier to figure out what you don't want to do than what you do want to do. But just be true to yourself, you know, really think about what you want, you know, what kind of lifestyle do you want, what kind of patients do you want to see. So after internal medicine, I could have specialized from internal medicine to be either a cardiologist, a GI doctor, a kidney doctor, and I decided I wanted to see a more broad range of patients rather than just focusing on one patient population. That's just my preference. Again, the flip side is now I have to know a lot. And sometimes it's really scary when you're in the middle of the night. I remember I was in residency, and there was a 24-year-old girl who came in and like liver failure. And I was up all night. I was up since 6 o'clock the previous morning. And I literally cried because this is a sick girl who's healthy, who's likely going to die, and I had no idea what was causing this. And she was circling the drain. She was really sick, and she had hours to live. Fortunately, I wasn't the attending at that time, so I had backup and help. But it was really emotionally taxing to do that. So it's not an easy profession at all, especially when you've been up all night and working a lot. So, but it is a great profession. So is that okay? Is
there a pediatric equivalent of a hospitalist? If you were to work in a specialty children's hospital, do they have?
They do, yeah.
Ooh.
Primary Children's does have a pediatric hospitalist,
okay.
especially. They actually now have laborists, which is actually OBGYNs who actually will stay in the hospital as well. They have, I'm not sure if they call them surgerists, but they have surgical folks who just stay in the hospital as well. So this is actually a new trend that's been started with internal medicine. Most hospitals now are internal medicine. A few family practice docs scattered out, but pediatrics is coming up and those other specialties as well. And it makes sense for a lot of reasons to kind of separate, because you don't really want to have a doctor who's been working all day coming in to see you 3 o'clock in the morning. I mean, that's not good for you, it's not good for them. I mean, I get to sleep all day when I'm working my shift of nights. So I'm relatively refreshed other than being up at 3 in the morning. But I've had sleep, I haven't been up all day. So, other questions about the medical side, what I do, the difference between primary care and hospitalist?
I had a question.
Yeah.
You said your board exam changed a lot from 10 years ago. What did you see that changes the most, you think?
I think in approaches of treatment. So the axiom that they'll tell you in medical school is that half of what they teach you is wrong. The problem is they don't know which half it is. And things really change, and I've learned a lot. I mean, and you can't keep up with everything. I mean, every 6 months I go through this ritual of the stack of journals that comes up, and I say, well, I'm never going to get to these, I throw them away, and then 6 months later it builds back up again. And it's really hard to keep up with the changes. But usually it's mostly in treatment as far as what the best approach is for stabilizing someone or giving a certain medication. So. Other questions about the medical side? So I'll tell you what I had.
So if you say you do a shift work with 13 other doctors, how many days a week do you work these hours?
So the way our schedule is, and a lot of us are part-time. I'm actually part-time. I'm 0.65 equivalent, and I have 0.5 administrative pay. So I'm more than a full-time person by a little bit. For a full-time person, it's usually 7 days on and 7 days off. So you do 7 days straight, which is a grueling 7 days, and then 7 days off where you don't have any responsibility. You don't have to take call. You don't have to carry a pager or anything like that. So a lot of groups around the country have kind of moved to a different model where you're not working. You don't have 50% of your time off. You're working more hours or more days, but you just have less patient load during that time because you have more people working at the same time. So it all depends on the group. We like our model the way it is. You know, you get beat up for a week and then you kind of decompress. You know, it's great for taking vacations and doing other outside activities as well. So, and currently I work 10 shifts a month, 10 night shifts, which isn't so bad. So, any other questions? Okay, let me tell you about some of the roles that I've had in the past. So at the hospital, we started a stroke program. For folks who come in. So a stroke is where either a blood clot, usually a blood clot, blocks a part of the blood supply to the brain. You have symptoms, you have weakness, or you have trouble speaking, or you have numbness. And so some of that treatment is really time sensitive. You can give medications that will dissolve that blood clot, but you have to give it within 3 hours or the risk of bleeding in the brain goes higher. So this is a very coordinated, multidisciplinary effort to have the ER involved, to have radiology involved, because you have to have them come in and get a CAT scan of the head to make sure they're not bleeding in the brain. That's the cause of their stroke. To get the appropriate lab work, to get the make the decision, are they a candidate for this really can be a deadly medication. And so that took a lot of coordination. So I was actually the program director that kind of coordinated that. And we actually got certified by the Joint Commission, who is this accrediting agency for 95% of the hospitals in the country, and they actually carry a lot of weight. So we had this big review every 2 years. They come in, and it's a big to-do. So I actually led that program for about 4 years. And that was a lot of fun to get all these disciplines together. You know, when they come to the floor, how the nurses treat them, how the therapists get involved, how do we pass information to the primary care doc, how do we make sure they get the right medications. And so it was a great teamwork experience for that. I was also a chief of medicine for 4 years at the hospital, and my responsibility was to oversee, basically be accountable for all the quality for my department members, and there were about 120 at the time. So it's a lot of docs that I'm accountable for. And I'd have to do things like do peer review. So certain events in the hospital will trigger it on that chart review. So if someone comes in and they die or they die unexpectedly, if they get transferred to the intensive care unit within 24 hours, and these other kind of issues. So I sit with the committee and we review the chart and have to decide, you know, was anything done wrong? You know, what could have been done better? And that's sometimes kind of hard to kind of review your peers and say, hey, I think you screwed up. And It's challenging. I have to write letters. I have to follow up with them. If there are behavioral issues, if the doc yells at the nurse, I have to deal with that because that's under my purview. Making sure that they have, so at the hospital, you just can't, I just can't go to Ogden Regional, for instance, and practice. You have to be privileged at the hospital. That involves making sure that I have the training that I say I have the skills that I have, all of the procedures that I do that I can show that I'm confident in them, I have the appropriate training. And so I have to sign off on the docs and say, you're asking for this privilege, yeah, you have the ability to do it or not. And some docs I said, no, you haven't done that in 15 years, I don't think you're qualified for that. Making sure their references are good, dealing with any behavioral issues that come up or quality issues as well. Also revising the department rules and regulations, make sure we have standard processes, how do we govern ourselves, things like that. So I did that for about 4 years, and that was a lot of fun, a lot of work for sure, but certainly a lot of fun. Currently what I've been involved in is I sit on what's called the Medical Executive Committee, or MEC. And this is basically a committee of all the department chiefs and a few other folks that sit on the committee. And basically, this is the top level of the hospital, that any medical decision that affects a medical staff member, so the physician, also affects nurse practitioners and PAs, has to come through that committee and get passed. So we pass rules and the regs and how we manage folks. So I sit on that committee, and I do this on a volunteer basis. This is about 3 hours a month that I sit on. I also now sit on the Credentials Committee. And so, just like I was talking about before, as far as a department chief, I had to make sure they met all the regulations. Now I'm doing this more globally. Things are changing a lot. Before, if you had what's called an aortic aneurysm, so basically a bulging of your main aorta, in the past, the only fixing of it is do surgery. You open them up, they put a graft around it. Now they can do things radiographically or radiologically. They can go through the groin, through the artery, and then basically open up a stent that opens up and just kind of provides a scaffold for that artery. And so we're seeing a lot of cross-specialty procedures. And so now we have to decide, well, who's qualified for this? If this is a new procedure, how do I know you're doing it well? If you don't have experience, how can you show me experience? And so we have to set up the rules of saying, what you have to show, how many procedures you have to do, what kind of training you have. Have you heard about the Da Vinci robot?
Mm-hmm.
So that's a big thing. I mean, this is really huge. And by the way, there's not much data to show that it works any better than the surgeon having their hands in there. But it's a big moneymaker for hospitals, and it's sexy. We do like the sexy stuff. So that's a big issue. Who gets to use the robot? Not many residency programs now are training. Now they are, but they weren't 10 years ago or 5 years ago, and people want to do the cool stuff. So how do you say, yeah, you're competent? The one expression I heard that really applicable is our committee essentially is the last line defense to make sure we don't get a bad doctor in the hospital, because there are a lot of bad doctors out there who are incompetent, who've had a ton of malpractice issues because they're just not very good at what they do for many reasons. And so our job is to protect the patients in the hospital, making sure that we have qualified doctors who come in. And that takes a lot of work to verify where they trained, what procedures they're competent in, how do you assess their competency. And now with all this cross-hybridization with specialties is how do you define that? A lot of docs aren't happy when you say you have to show me 20 procedures or you have to be proctored. For it. So for the robot, we actually say you have to find someone who has the privileges, and they have to watch you do 10 procedures, and they have to sign off on you. And so that creates a lot of issues for physicians, but our job is important to make sure we don't get bad apples that puts our patients at risk. I also do this is my other half-time job. These are kind of what I do voluntarily because I think it's really important. It's what's called the physician advisor. And this really gets back to these government regulations here. The big thing right now, as you're probably aware, is healthcare is really expensive and it's basically bankrupting the country. So what Medicare has done is change the rules of the game a little bit, and what they'll say is, well, there are two types of people that come to the hospital. There's the really sick and there's the not so sick. And we're not going to pay more money for the not so sick than we do, the same amount as we do for the really sick. So they come up with these really complicated rules as far as, well, how sick are they? What was the medical necessity for them coming in the hospital? Just because I say they come in the hospital doesn't mean they're going to pay for whatever I do. And so there's all this level of bureaucracy and regulation. And so my job as a physician advisor is I do medical necessity reviews. So when people come in the hospital, there's basically two categories of the not so sick and the really sick. The doc makes their determination, and then if it doesn't match what our case managers, who are nurses who kind of review it on many levels, say we don't agree, then I have to review it. When we get denials from the government, they'll say, yeah, we're not going to pay this. I review it, and I actually go and will argue cases with the Department of Health, with the Office Inspector General here in Utah, as well as argue, yeah, I think they were this sick, here's the reason why. We actually had one case of a person who was at LDS for 90 days, $800,000 bill, that the Department of Health said, yeah, we're not paying. And so I had to review all 4,000 pages of the chart, and we actually got the case. Not so sexy as far as the medical side, and I think it is important, but it is really just comes down to the finances and I think it's more appropriate. I mean, my job is not to win every case, and I mean, I'm not in the lawyer role to say I got to prove, win at any cost. I mean, there are a lot of cases where I say, yeah, they weren't that sick, you shouldn't have paid that much for it. But that's something I'm involved in right now as well. So, what else? I'm also involved too with patient engagement, so kind of service kind of stuff, as far as when my father was in the hospital a few years back. He was in the ICU, and it's really different being on the other side of the fence on many levels. One is, even though this is what I do, and I take care of my dad's equivalent in the hospital here, it's different when you're on the other side and not getting the communication from the physicians, not being explained to what's going on. Not being there when they talk to my father, and he's pretty much clueless on medical stuff. And he's like, I have no idea what they said. It really opened my eyes, and I could see what they were doing and what I was doing to others inadvertently, not realizing that I'm not explaining things well, or I'm not drawing the diagrams, or I'm not letting families have the time to discuss their concerns and really kind of flesh that out. And so I'm kind of involved in helping physicians kind of hone some of their skills as far as how can you do very, very simple things. So for instance, if you sit down with a patient, they did a study. So they had actors who were the same physicians, different patients, and they found that the patient perceived that you spent 20% more time with them if you sat down versus standing up. Same amount of time that you actually did, but the patient perceives it differently. And I draw a lot of diagrams now. I print out their chest x-ray and say, here's your pneumonia, the infection of your lung, and I circle it. If they have a problem with their liver or their gallbladder, I'll just get a picture and draw it for them so they can understand and really engage the patient. It's the right thing for the patient. I mean, if the patient doesn't trust you, if they're like, I have no idea what they said, they're not really going to follow your plan of care, and they don't think that you care about them. And patients thinking that your physician is involved is critical. Especially for these really sick patients, and when you're having these really hard discussions as well for end of life. So that's some of the other stuff that I'm involved with. Also with nurse-physician communication, as far as how it's really interesting. So 30 years ago, nurses and physicians would round together. I mean, that's doctor would come in, a nurse would get up. They don't do that anymore, which is probably good. But they would round together. Now the doctor's in and out before the nurse even knows the physician was on the floor. Obviously that doesn't promote a lot of communication as far as what the problems were, what we fix it. They have to, you scribble some orders down, they have no idea what you wrote because you're in a rush, so you're getting phone calls. And so I've been involved with how to improve communication between physicians and nurses, really for the benefit of everyone, for the patient as well as the physician as well as the nurse. So that's a snapshot of what I do. In my spare time, So I guess we're getting close to the time. Again, I apologize. I was hoping to get a little bit more sleep last night, so hopefully I'm not too punchy. So questions?
So as far as getting involved, how you got involved in the administrative roles, is there any requirements to get into those roles, or?
There were no requirements. I think there are certain skills that are important as far as how to have difficult conversations, so it's like leadership type skills. And Intermountain was great because they actually sent me to courses for being a department chief, a seminar or course for how do you deal with credentials, how do you deal with peer review. And so they really supported me through that. But there's really no specific training per se within medical school. But I think right now, I think hospitals and medical groups are really understanding that the leadership aspect of physicians is really important. And so I think we're trying to develop those skills now. And you'll probably see more of that as you're going through residency, as you come into an even medical school as well. Because it is crucial. How do you manage someone? How do you manage a group? How do you have difficult conversations and have to basically, it's really hard to discipline a peer. You know, I'm not any smarter than my other peer, but in my role, my responsibility now is to do this. I mean, I've had to suspend people before because they just did something egregious, and that's really uncomfortable because I know I have to call them up a week from now saying, hey, I need your help with this patient. And so how can you separate that professional relationship from the kind of transiently supervisory relationship? So, but it's really important, and there's a lot of training programs out there and courses, and if people are interested in leadership roles, I'd recommend, and you can contact me and I can get you some more specific information about it. So, Susan.
Do you think that because of that, medical schools are not focusing in so much on MCAT scores, GPA? They're looking more for someone that can communicate?
I think they are. I mean, I think right now, I think 10 years ago, if you had a surgeon on staff who was probably the biggest jerk in the world, but they were a good surgeon, most times you'd overlook that. But I think things are changing now. In fact, we've had situations in other hospitals in our system where top-notch, world-renowned people got booted off the staff because they were just jerks to work with. They treated people poorly. They were not good communicators, and they were not team players. And that's a huge thing, and I give Intermountain a lot of credit for that, because it's kind of hard to, cut off your revenue source, but it's the right thing to do, and I think you're going to see more of that focus on that. And you probably will see it now in your applications as far as looking at more, I wouldn't really call it a soft skill, they call it soft skill, but how do you interrelate interpersonally? It's a hard, challenging environment. I run a lot of codes, and it's a very intense situation when someone is dying before your eyes and you have seconds to act. And tempers rise, and everyone's just really has the adrenaline just flowing, and it's hard to maintain that calm. When things go wrong, it's easy to say, "What the heck did you do?" And just you have to step back and say, "Okay, how can we make this process better?" Certainly, that doesn't mean that you shouldn't call people out if they do things inappropriately. Certainly, how you manage that and where you manage that is certainly critical. But I think we're getting away from sweeping things on the rug and hoping they'll get better. So,
How has the Affordable Care Act affected the hospital and how you practice medicine because you've been involved in the leadership part of it, right? So I'm sure you've been able to see the changes they've done. So how has it changed, and also how do you think it is going to change, especially because a lot of, the other changes in the Affordable Care Act have been taking place? So,
That's a really good question. I think right now it's too early to tell. Right now you're just at the beginning stages. I think for some degree we'll be able to, for all those patients who were uninsured before, now we can actually get them into physicians because, like I said before, they're running a business, so it's kind of hard to find people to send uninsured patients to. And these are usually the people that are sickest because they've had years and years of not being able to take medications or get diagnosed or being managed. So I think in the long run it'll help us out as far as having patients who we can send to, they'll be better managed with their diseases. As far as the payment issues, that's kind of a work in progress. I don't think, one of the ideas is that you get paid for, right now, the biggest problem in medicine is you get paid for what you do, not for the quality you provide. Worked well for 30 years, but it's bankrupt in our system. So right now, you're going to get paid for an episode of care. So if someone comes in for hip fracture, for instance, the insurance is going to pay one fee for everything, for the surgeon, for the hospital, for the care they receive after, if they have to go to a rehab facility. They won't pay for a readmission if they come back into the hospital. And so I think that's going to start rewarding. And some of my pay is actually based upon the quality that I do. So I get measured on how well do I document, how well do I follow certain standards of care for pneumonia or heart attack or for congestive heart failure. And I think it's a really important step forward because you do more, you get paid more. In fact, the government a few years ago stopped paying for what they call never events. So for instance, someone comes in the hospital, they fall in the hospital, or they get an infection in the hospital, well, the hospital makes more money off of that. It's kind of perverse. But now they say, if they fall on your watch, we're not paying for that. That's your problem. If they get an infection because they have a catheter in their bladder, that's not our problem. We're not going to pay you because you did a bad job in the first place. So I think that's a really good move. I think it's going to be painful for a lot of folks. but I think it's the right thing to do in the long run. So, other questions? Yeah.
How common is the practice of physicians being payer blind?
I don't think it's very common at all. So Intermountain's a not-for-profit organization, and there's a lot of, you can argue both sides if that's appropriate. I don't think it happens very often, certainly not if you're in solo practice, and that's one of the reasons that drew me to Intermountain, because not only am I payer blind, I've never had once someone come to me and say, did you really need to order that test? I don't really think you needed that. I've never gotten questioned on the decisions I've made. And for me, it's a world of difference that I don't have to worry about it. As far as, if you're in the business, if you're in your own business, it's great, and a lot of docs do charity care, but you can't do that 100% of the time, because, how are you gonna survive? So I like the model I work in. It's not for everyone. Some people want their autonomy, want to run their business the way they do it. I enjoy not worrying about being payer blind, but I can't give you a percentage, but I would say it's probably less than 20% of physicians are payer blind in the sense that they're not necessarily affected. I get paid the same amount of money whether I see a patient who is uninsured or has great insurance. It doesn't make a difference as far as my bottom line. So, certainly someone is paying for it, but it all gets kind of put into one big pot that that Intermountain deals with. So for me personally, I think I like the way that I practice right now with being payer blind. So.
With physician shadowing, what things do you can see while we shadow a physician? I guess what I'm really asking is how accurate of an idea of what they do you get from physician shadowing?
It depends on how long you shadow them, right?
Would depend on the doctor.
I think it depends on if they're having a bad week or good week. I think I would view it as a snapshot, but really what I would pay attention to when you shadow a physician is how happy do they seem in their job. When they get a call from someone, they're like, oh crap, I got another admission. That's a big difference in being really excited. Now certainly we all have good days and we all have bad days, so you have to take it in context, but I would look at how do they interact with their colleagues, how do they interact with nurses or their staff. What are their motivations now? Do they just talk about money and the big house they're going to build? Do they talk about, I want to, cure the world. I want to solve this problem, make this process better. And I think that'll give you a lot of insight as far as their motivations. Now, certainly people change over time for certain. So you are seeing a snapshot, but that's what I would kind of focus in on. It's a really good question.
So are your peer reviews like the M&Ms of other hospitals, the morbidity and mortality?
Ours aren't. I know they have a travel program, and they get the whole department there, and it's really not like calling people out, so to speak. It's kind of like bringing it together. We have about 5 or 6 people on our peer review committee, and one person will review it, present the case, and we'll kind of discuss it. And it's really hard sometimes not to have, because you have to view it in what that person knew at that time. Obviously, you can look back in retrospect and say, yeah, that was a bad decision, but it's hard to. You have to not look at it that way. It's what would you have done in that similar situation? So it's similar, just not as large and probably grueling for the doc. We don't get the doc to put them in the room and put the light on them and say, so why'd you do this?
Right.
But they still get letters and we ask them to explain themselves if we do have questions, because we don't have all the information all the time as well. So try not to be accusatory with it. So.
I just wonder if you could elaborate on how you've gone about paying back your student loans. From my understanding, you went to a lot of undergrad loans and post-grad loans, is that right?
Yeah, so I was really lucky. I got a decent scholarship going to Penn, so I came out of undergrad with about $20,000 in debt. And at the time, it was probably an $80,000 education. Then grad school, actually, for the MD PhD, was actually paid for by the government.
Oh yeah.
And at the time, I'd have to give back so much time doing research and actually waive that requirement. So I took a few loans out there in grad school because I needed a car. Don't tell Deb that. So I had about $30,000 in debt coming out of that for all that education, which was really, I was very fortunate.
But you had to give an extra 4 years, right?
No, that was waived by the time I came out.
So like the MD PhD was 8 years, right?
That was, yeah.
So 4 years on top of normal medical school is what I was trying to say.
That's correct. So, I have partners now who are paying $2,000, $2,500 a month in student loans. They came out $200,000 in debt. I don't think he's unhappy. I think certainly he could use that money for other things, but I think it's manageable. And I know it's hard to. It's a lot of money, and unfortunately, medical school costs the same amount no matter what you do. And I think that unfortunately it's driving people to go to the higher paying professions. I see why people do it, but if you really don't enjoy it, you're gonna have a horrible life. This is a hard job. I mean, I was up all night last night. I had sick patients. You know, I wanted to be home sleeping. You know, it takes a lot of personal sacrifice. It takes a lot to, you know, be on your A game all the time, because anything less really is unacceptable, because people's lives are in your hands. I mean, that's a responsibility that you have to take on, whether you're sick, whether you don't feel like coming to work that day, whether you don't like that person. I mean, there's a lot of patients that, you know, they don't follow medications. They, you know, they'd rather do their meth rather take their insulin. And it's kind of hard sometimes, and I won't sugarcoat it. I'll let them know, like, you're destroying your life. You know, you're going to kill yourself by doing this. But you can't really let your, I don't know, disdain for their lifestyle really affect your care. They have to get the same level of care, and sometimes that's hard because we're all, I mean, you can't ignore your emotions, and I wouldn't suggest that anyone should. It's just how do you manifest that to the patient? Because really, if your job is to help them towards health, you know, calling them the scum of the earth really is probably not going to engage that patient and say, hey, they're really looking out for me. Thinking it is okay. You know? Expressing it is completely different. I mean, I mean to be flippant about that, but I mean, you can't change, don't change how you feel. It's just how it manifests, and are you really doing what's best for the patient? Are you just doing it because you're just kind of just pissed at the world or pissed at what they're doing? And it's really hard sometimes. So, and your spouses too. I mean, definitely go to that the meeting, because it's really hard in spouses. I mean, you're gone for a lot. I mean, doctors have a high divorce rate, and it's understandable why that is, and that's why I'm a big proponent of balance. Don't ever get into the thing where you're working 90, 100 hours a week. If that's what you want to do, that's great, but realize that there are consequences for that, and you're never going to get it all. So just decide to be true to yourself, and you may change over time of what your focus is, and that's okay, as long as you're honest with yourself. There's never a point of no return. I mean, it may be painful, it may, you know, take extra time, but there's really there's never a point of no return. So, is there another question?
It was basically what you just said. I was just going to see what advice you have for us going through med school and being a doctor, as far as managing a relationship with our kids and our wives or husbands.
You know what I do? So I think being honest with them. So what Barb and I have, so when I was on call or I'd be post-call, we always made an agreement that if I am post-call, we're not going to make any, you know, we may make arrangements, but if something happens or I can't come home in time, that she's going to understand and not get mad. So we never set firm kind of commitments. And I think it's just kind of managing expectations is the biggest thing. And I would start now, if you have spouses now, I mean, have them, they may realize to some degree, but I think having them talk with these other spouses and realize that their life is going to be much different for quite a number of years. And just be open and honest of how it's going. I mean, I think opening those lines of communication are critical. Doesn't mean it's going to be any easier, but I think at least kind of navigating that, negotiating that, and I think that in itself is relationship building rather than, you know, trying to overcommit and then just underperform, I guess, or underdeliver. So it's hard. It's really hard. This is not an easy profession. If you want to do it for the money, go into investment banking. Or seriously, this is not an easy job. There's a lot of responsibility with it, and so, yeah. Other questions? Sorry, I'm kind of taking up your time here. I know I'm standing in your way from spring break, so I apologize. So, again, please email me if you have any questions on anything at all. I'm more than happy, you know, to meet with you, talk with you, converse by email. So, I think one of the things I'd also encourage you as you go through medical school at the residency is find a mentor. Find someone who you can confide in, who will provide you with honest feedback, and someone you can lean on when you're having the tough times, both professionally and then also mentors in life. I mean, not be the same person, obviously, but I think someone doing this alone is really hard, and I think a lot of people, I mean, the rate of substance abuse, the rate of depression, suicide rates are higher in physicians, and there's a reason why that is, because it's not an easy job. It's emotionally taxing, it's physically taxing. I've been up, I work at the U and we lived in Sandy for a while, and there are times I'm driving home and I'm falling asleep at the wheel, and that's pretty dangerous. It's horrible. So, yeah. Anything else? Well, I appreciate your attention. You guys have been great.